We're going to have questions at the end.
So I have no slides. I know you're disappointed. I really want to be sure there's time for questions because my perspective is sort of from the national organization, which really doesn't impact you as much as what's going on in your state. So I want you to have an opportunity to talk with folks about how this can impact you in your practice. But I think it is worth a few comments about the AAFP's position on this and similar legislation. First and foremost, this is a huge issue. It's a huge issue in every state. You've already heard my state mentioned, Tennessee. It's a personal issue for us and for our patients, and it's a population issue for our communities. And it needs a coordinated effort. We talk about team-based care in lots of ways. Well, this is an example of another way of doing team-based care. How do we help take care of our patients, our families, and our communities? And family physicians are key to this. So one recognition is we are key to the provision of almost anything in this country. But when you look at the patients with chronic pain, we don't have enough chronic pain specialists. We're front line. We're often the ones taking care of the acute pain that later becomes chronic pain. We're also front line for mental health, which everybody is appropriately tying into the issue of addiction as well as pain in general, and family physicians do this. The e-prescribing plays a key role. This is part of learning how to use technology well. And I'm going over some of the positives. I'll come to the negatives in just a second. A PMP, a prescription monitoring program, is key. The trouble is, and we have all these wonderful electronic technologic aspects that are just as siloed as our paper systems. The whole point of this is that we're supposed to be able to have this communication. It does not go on at any level, and this is one of those that makes no sense, that every state is different and that you can't have communication and centralization of this. You need a unified system. Education has to be a part of the process. It's really important to recognize, though, that the AAFP does a significant amount of education even before this was a crisis. It's part of what we provide for our members. It's a big part of what we do for our residents. The one key will be medical students. That's somewhat out of our purview, but we're certainly pushing for that, especially in these days of scope of practice discussions, which is different from state to state. Non-family physician providers and prescribers need education. However, family physicians don't need the same level, and that's a real concern for us. Patients must have access to appropriate care. And I appreciate the comments from Terry that we don't want to limit the right use of drugs in the right situation. And there are a lot of things, though, that can unintentionally limit access. We also cannot increase the administrative burden that family physicians or any physician experience. And they're already huge, and unfortunately, every law, by definition, increases administrative burden. So there's got to be some good benefit for that if you're going to do it. And there must be physician input for any legislation. So these are some of the standard aspects from the Academy. Similarly, this is a state-by-state issue. So it's not something the national organization can say, oh, here's what has to happen. We don't have that kind of power. We're certainly involved at discussions with the current administration and their leaders in different offices, but each office is a little different, and then what each state does is different still. New York is a tremendous example of being involved and trying to impact legislation with some success and some loss. But I think you're demonstrating how states should be doing this, which is ensuring that the physicians and the legislators communicate. I think, as you've heard, we've got to be careful about unintended consequences, and they often come up and surprise you, and it's sad to hear that sometimes when they're there and we all say, oh, that's a bad idea, but we can't fix it. That doesn't sound like a good answer to me, but I know that's what happens with legislation. There's also, as we said, the mandatory education for other providers is certainly key. Changing hydrocodone to Schedule II certainly has a lot of benefits, but they're the maybe unintended consequences of changing access. Actually, that was part of the intended consequence. Let's limit access to this definitely overprescribed, overutilized, and dangerous medication, but in so doing, there creates some limitations for patients' access that impact us. Now, I may be wrong. Does New York's law allow 90 days for the hydrocodone?
It does. If you put on the front of the prescription code D, and
Okay.
it's chronic pain, you can prescribe 90 days.
Okay, and that's an important addition that I didn't know was there initially, because in the absence of that, then you have to ensure that patients who already have access issues can then see physicians for that medication. Now that begs the argument, is that the right drug for chronic pain? But we all have patients for whom the longer acting don't work. So you've got to be careful with that because we already have an access issue for primary care. There's also, in addition to the administrative burden, anything that criminalizes medical care is of serious concern. And for example, even though there are exceptions, when you have that exception, then there's the administrative burden that you're supposed to contact folks that you had an exception, which I'm sure will not go smoothly, and will raise flags, and you'll forget. And when you forget, then what troubles me is, as you said, I'll use your quote, you may get a visit. How many of you are looking forward to a visit? Yeah. It just sounds bad at every level, and you know it's not going to go well because it's rarely a congenial visit where, hey, I'm sure there was a problem. It's going to be, what did you do? I mean, I'm sorry, I don't mean to put words or expressions in other people's, but in general, that kind of thing, it's usually you're going to assume, prove that you're innocent initially, rather than I'm sure there was a mistake. And that criminalizes, it also increases administrative burden, not just for our organization, but for the regulators, because that's time somebody has to spend following up on something. So that's a troublesome aspect. And ultimately, while this is not an academy policy, this issue is not just a New York issue, as we've heard, it's national. And as we're looking as an academy of talking about team-based care, it raises potential for things that instead of each member of the team having more and more things to do, is looking creatively for points of commonality. For example, the final common pathway in all of this is the pharmacy. When you think about it, whatever I write, do, e-prescribe or handwrite, somebody has to fill it, and they're filled at pharmacies. And one of the challenges of that is there a way to be creatively start to allow pharmacies to be that point of final observation? Again, not necessarily regulation, but they're going to look at that. Pharmacies should have the capacity to look at a unified PMP and notice scripts from several places, which can raise red flags, which doesn't mobilize legal response initially, it mobilizes communication. Is there a way to mobilize so the pharmacy says, hey, by the way, do you know this patient you just wrote a script has 3 others? Much of the time we'll go, no, thank you for telling me, and it allows communication. The downside of that is you start to bump into things like HIPAA and communication. This is where laws and administration impact the common sense care. But are there ways we can start to look at that I think would be important? And the final aspect I was remembering as I was talking about this, when you looked at the exception for the emergency room, that certainly makes sense. However, how many of you see people for acute trauma and acute injuries? And you might indeed say, even though 9 out of 10 doctors prescribe Tylenol, you believe hydrocodone might be appropriate. Only if yeah, we all do that. The downside is if you're not an ED and you're doing that, and I know it's for acute management, there are probably differences in the law that I'm not as familiar with, but there are times we may write 5 days, and yet now we have an administrative burden potentially of having to check a PMP for something that is a short-term medication for an appropriate use. And in some ways that's legislating and having us prove that the care we're providing is appropriate. That may not be truly what how the law would be interpreted, but I had that concern as I heard that presentation. So I don't have great answers, but I appreciate being part of this discussion, because the other thing I can do that's a really important role is take whatever you're doing in New York back to our national organization, and we also take it back and forth between other states. We create, as Dr. Kaplan, your president, has gone to other states to create an opportunity for communication about innovative approaches, so too we on the national level can do the same sorts of things. So thank you, and look forward to hearing some of your questions.